Hi, this is Brian Kim. I'm going to share with you case number 94 in the best way to do cataract surgery series. This is a patient you'll see as soon as the patient gets on the table and we put the speculum in, the patient's eyes go straight up into the back of her head. And so this patient has a very strong Bell's reflex, and you're going to see how I'm able to use an indirect way to fixate the eye without using forceps, because the patient can resist you, they can feel the forceps, they can cause trauma to the eye if they suddenly resist you. And this is an indirect and easy way to control the eye using the cannula to fixate the eye. So you can see here this patient's looking straight up with a very strong Bell's reflex, having difficult time controlling the eye. I'm using the cotton tip, I'm trying to turn the eye downward, and you can see this patient's resisting and looking around. So I'm using the cotton tip to control the eye. I'm using a corneal marker which will help me center and size my rhexis. I'm turning the eye to the left upward, and then I make my paracentesis incision first on the right side and then the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see this patient's really having some trouble. I switch to another cotton tip because the other cotton tip got soaked in the process. A wet cotton tip is more slippery, and so switching to a dry one gives me more control. This is some intracameral lidocaine and then some dispersive viscoelastic to fill the chamber and to flatten the anterior capsule. Use the cannula to control the eye for the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel into the cornea, and then when I'm ready, I enter. I push some more viscoelastic, and then I'm going to hold the eye with the cannula. As I do my rhexis, I puncture and go down, grab the right side, and I go around circumferentially. But I'm using the cannula to prevent her eye from going all the way up into the back of her head. And again, this is very easy because I'm able to lay the cannula on the brow. And so this is a very easy way to control the eye for the capsulorhexis. This is a capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, rotate the tip down, get a nice wave, decompress on the left side, get a hydrodelineation wave there, and then I start to spin the lens on the right side. You can see as soon as I let go of the eye, it goes straight up. So I use the chopper now, lift the incision, go in with the phaco tip. And because this part is now a two-handed technique, the eye moving upward is really a non-issue because I have 2 points of fixation. It's really more important in the beginning of the case. I place the chopper under the rhexis edge, out to the equator, contra-incisionally, place the phaco tip vertically, sub-incisionally, grabbing both ends of the lens, crushing it, and dividing it. That's the double chop, placing the chopper around the right heminucleus, bringing it centrally towards the phaco tip, crushing the right heminucleus. That's cross chop. Getting the chopper around the first quadrant and crushing it between the chopper and the phaco tip, and then emulsifying the lens piece. Placing the chopper around the second quadrant, pulling it centrally towards the phaco tip, crushing it and dividing it, and then emulsifying that one as well. You can see this lens has somewhat of a density, but it's not ultra dense, but it does have a chalky density that it does break up. It does require some force to crush it. Place the second heminucleus in front of me, placing the chopper around the lens piece, pulling it towards the phaco tip, crushing it, and then using mechanical forces to crush the lens into even smaller pieces, and then emulsifying the lens pieces. The last piece I just pull up with some vacuum, crushing it and sandwiching it between the instruments, and then emulsifying the lens piece. So that's the endonucleus. I'm going to grasp the epinucleus with some vacuum and it pops up. You always want to make sure that the bag is not attached to the epinucleus as it comes up. And the best way to assure that is to have a good loose lens. And that happens during the hydrodissection. You want to make sure that the lens is nice and loose. I always keep the chopper between the phaco tip and the bag just in case the bag comes up. And I'm just very carefully using that vacuum in a very controlled way, making sure that the epinucleus comes out without a problem. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the eye in a handpiece. I always start subincisionally, going after the subincisional cortical material, and then go around circumferentially. I switch to polish mode and polishing under the rhexis edge. In under polish mode, you can be more confident that you're not going to snag the capsular bag and stretch the zonules. Start to point the tip down, polishing the posterior capsule surface as well, because there's some fine lens material that can be adherent to the posterior capsule. You can see there's some subincisional fibers that are still adherent there. And I'll go after that in a bit here. You saw that I grabbed a little bit of that remnant and then switched to cortex mode and was able to remove it. I placed the cannula in the subincisional fornix and pulse it, but there was nothing there. It was pretty clean. And I fill the capsular bag with cohesive viscoelastic, and then I'm using the sweep to polish under the rhexis edge. Polishing under the rhexis edge just provides a nice way to clean the lens epithelial cells in that area. I widen the incision with the diamond blade. This is a 3-piece lens. Turn the bevel to the left. Deliver the leading haptic into the capsular bag, which comes out flat. I rotate my hand so that the barrel allows the optic to come out flat and the trailing haptic pointed to the right. And then I use a Maltzman to dial in the trailing haptic. Go in with irrigation off, activate irrigation, go under the rhexis edge, remove all the viscoelastic from within the bag. I like to polish a little bit more under the rhexis edge. After that manipulation, it does seem to liberate more lens material. And once I'm ready, I go ahead and remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So this, again, is a patient who had a very strong Bell's reflex. This is the patient's right eye. So for a right-handed surgeon, it's really quite easy to use a cannula to control the Bell's reflex. Since the eye is moving towards the left on the field, I can use my superior paracentesis incision using my left hand to use a cannula to control the eye and fixate it. I can literally place the cannula within the incision and place the syringe in my hand against the brow, on the upper brow there, and it allows me to have a resting place so that I can control the eye so that it doesn't go up. And this is really, in my opinion, the easiest way and the least traumatic way to control the eye with a strong Bell's reflex. So I hope this was helpful to you, and I thank you for your attention.